critical as we confront the disproportionate burden of non-communicable diseases, which claim more than 3 million lives every year in the African region, and many of them are premature. I'm sure you all know when you die before the age of 70 is defined as premature mortality, and most of our people in the region die before the age of 70. This is projected to exceed the combined death from infectious, maternal, nutritional, and neonatal diseases as the leading cause of death by 2030 in the African region. Many NCDs, including cardiovascular diseases, diabetes, sickle cell, cancers, are preventable or treatable, yet they remain out of reach for far too many people in our region. Cancer in particular is a growing public health crisis in Africa, with more than 1.5 million cases every year and 750,000 deaths every year. Among women, we all know that breast and cervical cancer accounts for nearly half of all cancers in our region, yet most are diagnosed late and treated inadequately. This is driven by persistent systemic barriers in our region, namely low awareness and limited access to organized screening, inadequate availability of essential medicine, diagnostics, and treatment devices, shortage of trained healthcare workers, weak referral systems and fragmented care pathways, and high out-of-pocket costs and limited financial protection. And this must change. No woman should die or suffer from a disease that is both preventable and treatable. In response, the WHO Regional Office for Africa launched what is called the Women Integrated Cancer Services, called the WICS initiative in 2023, integrating breast and cervical cancer screening and treatment within the primary care with support from Roche. WICS is built on simple but powerful principle that is integrated, continuous, and women-centered care across the full continuum from prevention, early detection through to treatment. It offers a practical, scalable model that strengthens the health system as a whole. In practice, WICS creates what we call the one-stop shop. The same woman accessing multiple services, breast, cervical, hypertension, diabetes. So once the woman accesses the facility, is sorted for all the major NCDs, the same primary healthcare team delivering the integrated care, there is shared laboratory and diagnostic platforms, and the integrated health information systems. This is not only better care, but also smarter financing because it's cost-effective. Integrated service delivery reduces duplication, improves efficiency, and delivers better value for money. Today in our region, Kenya, Cote d'Ivoire, and Zimbabwe are implementing WICS, and the momentum is growing. These efforts are already reducing diagnostic delays, expanding access to life-saving care, and reaching underserved populations. These achievements are made possible through strong partnerships. With partner support, the WHO Africa region is assisting countries to adapt national cancer plans, train healthcare workers, equip facilities to treat precancerous lesions at the primary care level. Importantly, WICS is no longer a pilot. It represents the future of equitable, effective cancer care in the African region. This model must now be scaled up to reach the women who need it most. Too many women still lack access to screening, diagnosis, and treatment. Too many health systems remain under-resourced to deliver the care women deserve. Eliminating cervical cancer and reducing breast cancer mortality will require the sustained political commitment, smart financing, and coordinated action from governments, partners, communities, and individuals alike. To sustain this and scale this momentum, I urge all of us, including member states and partners, to embed the WICS initiative within the national primary care system, commit to health financing and policy reforms, and institutionalize integrated models, because that has shown to be cost-effective and it works. We should share tools, models, and evidence across countries to accelerate learning and scale innovation. The WHO Regional Office remains fully committed to leading the regional response as we have started. We will continue to provide technical support, build capacity, and advocate for increased investment in sustainable integrated programs. The WICS model sets a new standard going forward, grounded in equity, access, and health justice, ensuring timely, quality, and compassionate care for all women. Let this event be a catalyst to accelerate implementation, to amplify local solutions, and align our efforts around a shared vision for people-centered integrated care. We call on all member states to accelerate implementation of the Global Strategy for Cervical Cancer Elimination and the Global Breast Cancer Initiative, and to place women's health and rights at the center of the universal health coverage.
How we are measuring return on investment so that we can compete for those limited resources.
Thank you very much
Jemima,
for your attention.
my question is that often we measure the results of digital health at the end. We do studies looking back.
Sorry about that, that was not us. Thank you very much, Prof. Regretfully, the representative from Africa CDC is unable to join us today, but we have had a regional perspective already from WHO. So we'll move on to our hosts. And Dr. Oluga, the Permanent Secretary from the Ministry of Health, sends his regrets and has very generously, a very short notice, we have received a representation by Dr. Melly, the CEO of the National Cancer Institute, and who will be reflecting on the Kenyan perspective and approach to this challenge. Welcome, Dr. Melly, and thank you for stepping in.
Well, thank you, Dr. Ebere, and my fellow panelists, all the invited distinguished guests. It's a pleasure and an honor to speak to you this morning, representing our Ministry of Health, just to give a perspective on our country approach in addressing this major catastrophic disease, which is of public interest as well as personal community interest in our country. I begin my presentation by appreciating that the leadership in this country has big and great plans for improving healthcare in this country, and this was very intentional before this administration in our country was elected, and they committed to make universal health coverage a reality as one of the commitment and a promise to the people of Kenya. It's also important to mention that while we are discussing how to, improve cancer care in Kenya and in the region, without improving the entire healthcare system, we are not going to succeed to address the burden of rising cancer in our regions, because at this point where we are discussing integration, then definitely it's important to invest in the entire healthcare ecosystem. And I want to really appreciate our co-hosting partners here, Amref and Roche, who have invested heavily in making sure the healthcare system across board is up and alive. In Kenya, our country, through the Ministry of Health, was very deliberate. There are clear policy reforms that our Ministry of Health had to enact 3 years ago to make sure that we have better healthcare to every Kenyan. And one of them was a Social Health Insurance Act to make sure that there is predictable financing of healthcare for all Kenyans. And the other one was a Digital Health Act that was also very important to make sure that we utilize opportunities that digitization of our healthcare would bring to make sure that we not only improve outcomes, but we increase efficiency, and we are able to track all our services end to end. We did also appreciate that at this juncture where there is a rising burden of NCD, we have to shift from treatment to prevention. And therefore, we did enact a Primary Healthcare Act that enabled, establishment or recognition of what formerly most of our countries would consider them as community health promoters to be community health volunteers to be community health promoters who are now recognized as level 1 healthcare workers in this country, and they are playing a very critical role in the community. As we are talking about integration in cancer care, for us to screen our patients, for us to create awareness in the community, as we create awareness on how to prevent the other NCDs, we do integrate how then do we address the rising burden of cancer from that level. And we also empowered our community hospitals. We did enact facility improvement fund act that also enabled our grassroots facilities to have predictable financing for the services. Because traditionally we've invested in national referral hospitals, yet our problems begin from the community. So it's been important to make sure that there is a policy shift in our country. And through those 4 laws which Ministry of Health enacted, we have now a robust infrastructure to deliver universal health coverage. And in delivering universal health coverage, our Ministry of Health is prioritizing social health financing for the public, as well as building capacity in our human resources in health, and also ensuring that we have commodity security, certainty across the entire continuum of care, and finally embracing digitalization and optimization of utilization of data in planning as well as policy making. Now, as a country, we have recorded more than 44,000 new cases of cancer every year, and we have more than 29,000, patients dying from cancer every year. And more than 50%, as my colleague mentioned, would be represented by breast and cervical cancer. As a practicing oncologist, every day we see women diagnosed with these 2 cancers that, other regions who have done very well in investing in primary health care have been able to prevent. Cervical cancer should not kill anyone. With the clear strategies that have been deployed successfully in other countries, I do believe that in Africa, in Kenya, we should be able to embrace that. We've made progress here in Kenya, and we are aligning our local policies, adopting, regional initiatives that are giving a clear framework on how we should address this rising burden of cancer. We are working towards eliminating cervical cancer by 2030. As we all know, we have targets, and every country here has. We've made progress in investing in vaccination. We've made progress in investing in screening for early detection, proper diagnostics and treatment for our patients. And the policies that the government has put in place have mainstreamed, cancer care into it. And as we handle the basics of prevention of other NCDs, there is a lot of messaging as well in addressing, prevention of cancer in there. What we know is that this era of precision, oncology, where cancer treatment for advanced disease is biomarker driven, the cost is certainly catastrophic. More than 90% of our patients in our country cannot afford, these expensive novel therapies that are currently in the market. And therefore, our hope in addressing this rising burden of cancer is to invest heavily in prevention. And I think I can't overemphasize that. Innovatively, as a country, what are we doing to make sure we deploy more resources in cancer care? As we work with our partners who are here, I am always proud to mention that Roche probably is our #1 partner that invested in our cancer care efforts more than a decade ago. And Dr. Gidinji agrees with me because he's been involved, in this space quite longer than myself in building health systems. And I want to appreciate that even as we work on community interventions, we have a very robust Empower program, which through a private partnership engagement with Roche, we've been able to develop an end-to-end digitized cancer screening program with linkage to care, which is scalable, and it is something that we are happy to share. Our country, as I conclude, has really invested in domestic financing of cancer care. Comparatively, we have, through Social Health Authority, been able to deploy resources in primary healthcare fund, and there is a clear framework now to fund screening in the community through that fund, and treatment through our social insurance fund. And because this disease is costly, where we can, we have also an addition of, funding from the same Social Health Authority to address critical illnesses and chronic illnesses, cancer being one of them. We've also embraced access programs. I think this is quite innovative. Access programs have also really helped us reduce the cost. While we commit to our manufacturers whom we've partnered together, we've access programs with Roche, with Pfizer, with Merck Foundation, the major big boys in the pharmaceutical sector. There are many other strategies that we have deployed, and when an opportunity presents itself, we can discuss further. Thank you very much.
Thank you very much, Dr. Melly, and apologies for cutting short. We will have a little bit more time for further case studies discussion later on in the program. And so at this point, can we thank our keynote speakers, and I'm going to ask them to step into the floor, and we invite our panelists to join us. And while the panelists are walking up, we've got a really short video to share. If that is ready, can we go with that, please? Thank you very much. Thank you, keynote speakers. Thank you very much, and apologies, it looks like there's a problem with this sound on the video. Up on time. A reminder that one of our presentations will be in French, so if you need an interpretation, use the QR code, which will be displayed again to download Interprify, and you can put your headset on and listen to a translation. And if you have any questions for our French speaker, you'll have to use that, as she will use that so she can have a translation. But thank you, and I'd like to welcome our panelists to this session so we can go into a little bit more detail on the topic of today, which is cancer care, particularly in women, and the financial implications thereof. I'll start, we've switched the program as you have it around just ever so slightly because we think it's important to center the patient journey in our conversations before we actually talk to hear about the case studies. That way we are looking at the impact of the case studies through the lens of the patient experience. And so it gives me great pleasure to welcome as our first intervention in this session, Dr. Gichuru Kairi, who is a clinical oncologist and the president of KESHO. And she is going to give us a view on how financing failure shows up, particularly for the breast cancer patients' journey, and how what they are thinking about, what they are advocating for to make a change. Welcome, Dr.
Thank you very much, Dr. Kere, and I'm very grateful to have this opportunity to represent the 3,000 oncologists and allied support for oncologists who look after cancer patients in Kenya. And we look at, a vision where we shall have optimal health financing, where the domestic financing will move from out-of-pocket expenses to a way where we can have public and government support in supporting our cancer patients. Now, optimal financing directly improves cancer outcomes. Immediately, we see in the breast cancer patient, in the mid-term and in the long-term in survival and reduction of morbidity. Early detection, as we've heard, is easier to diagnose. A little lump in the breast, an early cervical lesion, it's cheaper to treat, and it directly influences mortality and morbidity. If you have a tiny 2-centimeter lump, we need to make a diagnosis with a pathologist, we need molecular tests, we need a radiologist, we need to stage the disease, we need to radiate, we need the medical oncologist to give treatment. That is complex. That requires a multidisciplinary approach. That is expensive. And therefore we are stuck in treating emergencies of late disease in stage 3 and 4, which is expensive and has very poor outcomes. We need to move to even prevention and screening so that we can do vaccinations, we can be able to intervene on lifestyle changes, reduce cigarettes, treat STDs, and so on and so forth. In our country, even aflatoxin exposure. But we're so stuck on late disease that we don't get to some of these actions. Professor Kofi today has spoken about one-stop shop. Very effective for cervical cancer. We screen patients, but they live so many kilometers away that they can't come back for their biopsy report. So we need a system where they come, they get everything in one stop. They don't have bus fare to come the next day. This integrated care, they'll have their pap smear, they'll have their HPV test, they'll be diagnosed with early cervical cancer and get their LIPS treatment in that one-stop shop arrangement. It can't work for all malignancies, but it definitely makes a difference for the big burden. Then we come to adherence and compliance. Most of our patients live hand to mouth. They earn less than $1, which also feeds their family. So they've traveled, and we've told them you have a locally advanced breast cancer, and we need you to get treatment, which means moving away from home and coming for radiotherapy for 6 weeks. Yet what they earn is what their family eats. So we don't get adherence, we don't get compliance, we don't get good quality of care. Radiation is interrupted. And because these patients don't have access and cannot afford, we have very, very bad outcomes. We give neoadjuvant treatment, which is the early treatment to shrink the breast lump. We want within 4 weeks for this woman to go for a mastectomy, but there is no access and there is no money. She progresses. By the time she gets the assessment to be able to do the mastectomy, she's in stage 4, and now we have to run around and change the treatment from surgery to chemotherapy and hormonal treatment, which is lifelong. So it is complex, and we still need to aim to give primary and secondary prevention. We don't think about the familial clustering of disease because we are so heavy on the high mortality and morbidity. It's around 18% in breast cancer in our setup. We should be looking for modalities in which we can screen, have targeted screening if we can't afford universal screening. We need to make sure that we treat correctly, we have proper protocols, and we also look at survivorship, hospice, palliation, and pain control, as well as rehabilitation. So there is a big gap between the patient experience and what we are creating in policy, and that needs to come together. Time to treatment is a predictor of survival, just like early detection is. Treatment continuity has impact on overall survival. But all this, Dr. Ebere, needs to be data-driven. We need to budget based on evidence. We need research, we need data generation. For example, when we are talking about screening, our breast cancer disease seems to occur earlier. There seems to be different genetic markers. Those who work day to day know that we read about BRCA1 and BRCA2, but our patients are usually negative, yet you can see a strong familial clustering. It means we need to investigate what genetic markers drive our disease. If we come to doing mammographies in the international guidelines, starting at the age of 50 years, we're going to miss close to 60% of our disease that has occurred earlier. So it needs to be data-driven, it needs to be evidence-based so that we can come up with our own treatment protocols. And I think I'll stop there, Dr. Ebere, because I have a lot to say about what I think are the innovative measures we need to do to grow homegrown solutions. Thank you.
Thank you very much. Thank you very much for reminding us that there's a patient with a difficult journey in the center of this conversation. And following on that same theme, I'd like to invite Ms. Benda Kithaka, who is the founder of the Kilele Health Association, to continue on reflecting on these from the patient perspective. So welcome. Thank you.
So good morning, everyone. I hope you can hear me, and I hope I didn't trip the microphone. I would just like for us to have an exercise, a brief exercise as I'm starting my conversation with all of you. Just close your eyes for a moment, all of you. You can trust me. I'm not picking anybody's pocket. Imagine a woman who is dear to you, or a girl who is dear to you. Put a face to that person. I'm sure you can name them as well. And I'm pretty sure if you think even deeper, you can see what they're doing this morning as we're sitting here having conversations about her. You may open your eyes now. Some of us thought about our mothers, others thought about our daughters, others thought about the policy maker in government who is making a decision about what they're going to be financing. Some of us saw different women in Africa working, doing what they do best. Jackie mentioned very well earlier today when she showed us that this is not just a conversation about financing, it's about the value of the life of that woman. And why I've made it personal to you is because my intervention is not bringing about all the things that the other panelists will be talking about, which is the economics of financing health in Africa. It's about bringing that to reality, to realize that any one of us, I'm a woman, she's a woman, and we all could be at risk here. But even as I'm speaking about the personal, I want to bring a case study for you of the woman I thought of as I was closing my eyes. She's called Sophie. Sorry, I should rephrase that. She was called Sophie. Sophie came to my organization about 6 months ago, 13-year-old girl coming from Narok in Kenya who was treated for breast cancer. Let that sink in. Now, we will never know whether it was breast cancer or not, because Sophie at 13, before she could be even diagnosed or anything, the doctor at the clinic did a mastectomy. When that happened for Sophie, the second thing that happened is the wound would not heal. That was in a clinic that was in a facility in Narok. She was brought to Nairobi, and that's how we came to know about her. And we navigated this girl, not woman, through the healthcare system. She had a 4-month delay from October last year to chemotherapy and radiotherapy that started in February of this year. We lost her last month, and we buried her. Sophie represents a girl, but there are many women in Africa that will be called data, that will talk about 80% of survival rate, or rather death out of cervical or breast cancer. And in the West, women are surviving. When Africa has 45% survival rate, in the Western countries, women up to 80% survive these diseases. Why is that? Financing is one of the reasons. But financing cannot work in a silo. Why is this for me? Because when we look at the case of the surface of this world, referral pathways are critical. When you talk about a patient who has to navigate from Narok to come to Nairobi for treatment, that distance requires that she also has to think about accommodation. She's 13 years old in a culture that is very communal. So they are traveling 5 of them to bring her to hospital. That cost for 5 people to stay in Nairobi is out-of-pocket expenses. The second thing, the culture around care. When we think about diseases like cervical cancer, where we don't talk about sex and sexuality in Africa as broadly as we ought to, and we know it's caused by HPV, which is vaccinatable, we need to start thinking about how do we ensure these conversations are happening at the community level so that people understand their risk factor. That needs to be financed. When you talk about health literacy, it's not about giving pamphlets or putting PowerPoint presentations. It's about making this woman, this community, understand their risk profile, understand the access issues where they can be able to be screened early, vaccinated for girls, accessing care, and being able to survive the disease, and therefore early detection, as Dr. Kerry has spoken about. The other thing that we need to think about is digital tools. Most often we find that we're moving our patients, moving bodies, as opposed to moving access to care. And I'll say that Jackie talked about innovation without access being an extra cost. For me, it's actually exclusion. When you give innovations without access to people, what we're doing is excluding them from the healthcare system. How is this so? When we think about our healthcare systems, they're very much pull. We expect the person will feel ill, they will come to the healthcare system, and then they will be treated, and then they'll go away. But we've heard that a woman will take at least 9 visits to the facility before an actual diagnosis is done. And when that happens, this woman who has to visit 9 times, most often we imagine that she'll come today, come tomorrow, the next day. Sometimes it takes 2 years for them to navigate that healthcare system. So when we talk about the cost of healthcare, it's no longer about a singular approach. It's no longer about a single visit. It's about ensuring that we remove all the barriers that have been spoken about earlier. Now let me talk a little bit about barriers, and I'm about to finish. Most often we want to blame the woman, blame the healthcare system, but we're also not looking about the singular approaches that we have to health. For example, we'll talk about diabetes, we'll talk about cardiovascular disease, we'll talk about cancer, we'll talk about obesity, each in singular approaches to the healthcare system. And yet again in one of them is a gain for all of them because they are all NCDs. So when we think about siloed approaches to healthcare, we need to start thinking about what are the touch points that this woman is coming to the healthcare system in. No matter where she's coming into, let's improve health literacy so that we have these women taking on the other various comorbidities that could potentially be raising the cost of healthcare. I'll come to policy. I think one of the things that's really aches us from the civil society approaches is that often when we talk about financing for healthcare, we're thinking about money and we're thinking about pouring money into the system. I want to differ a little bit with that and to say that money should not be so much being in the system, putting as much money as we want in the healthcare system, as the money following the patient journey. And so that we know that we are addressing the various barriers that could potentially happen for this woman. A case in point, I want to appreciate our partners here. For example, Roche and Amref Health Africa. Investments have been done in the healthcare systems. And we know that today, as we are talking, Dr. Melly mentioned, there is the policies that have been instituted in Kenya and across Africa in various countries to ensure that screening is available, to ensure that diagnosis systems are available, and to ensure that treatment access is being made possible. The only challenge with that is we're also not looking at the patient journey and how they're going to access this. I talked about moving bodies as opposed to moving knowledge. If, for example, we utilize digital health systems and we start looking at how do we address the issue of the healthcare worker limitations to ensure that diagnosis can happen by moving the samples for the biopsy, so that the woman doesn't have to move, she will get that diagnosis and then be given a pathway for treatment. Sometimes that diagnosis may not even say that she needs to be brought for radiotherapy. It may be just surgery, at which point we've reduced the out-of-pocket cost for this woman. Lastly, moving beyond paper interventions into real coverage for women. We have the policies, we have the intentions, and sometimes the political goodwill. What though happens is priorities. And this is where I want to be bold to suggest that healthcare financing for Africa needs to be thought of beyond what we've seen as what works. For example, in Kenya we did Eurobond. This was to finance our debt. Why don't we have a health bond that can finance healthcare so that we ensure that our women and girls and men and the people who need healthcare are able to experience healthcare without out-of-pocket expenses, or the burden should not be that 80% of X to 20%. The second thing for that to happen is to start thinking of sin tax differently. When I talk of sin tax, most often what comes to mind is alcohol as well as tobacco. And what often happens in African governments, with it as civil society, is yes, they will be taxed, but the money will go to a pool that finances all of healthcare. What we are asking, we know, for example, alcohol and tobacco are precursors for cancer. For cervical cancer specific, tobacco has even been associated directly. We know obesity is one of the risk factors for these two diseases. And we know if we put sin tax on sugar and other products that are highly high sugar content, and this is directly channeled to cervical cancer or breast cancer initiatives, we know this will bring interventions that are directly linked to the cause and the outcome for the woman. What I'm suggesting is that we start looking at healthcare financing from the woman's perspective. She will never know where the money is coming from. What she needs to know is that the service can reach her at the right time. And when we think of innovations that we're bringing, we need to start thinking, how do we urgently get them to the women so that we reduce the number of days that it will take for diagnosis and the number of days it will take for treatment, and start saving lives now. Thank you so much for your time.
Thank you so much. Thank you. I mean, we can listen to this for a long time, and last we're running late, so we're really trying and catch up. At this point, we will move on to the case studies, and these are various approaches to addressing the financial constraints, and we switched this and had this the clinicians and the patient's perspective first, because we want to understand those case studies through that lens. So as our next speakers take the mic, I want you to be thinking, how does this solution address the challenges that we've just heard? And then second question is, how do we scale these? What are they transferable from the countries that are modeling them, and how do we scale them? So thank you very much. And I think our first speaker in this section is going to be, we're going back to the host country. The Kenya case study will be presented by Dr. Kandi Ngochok, who is the Deputy Director for Claims Management at the Social Health Authority of Kenya. So Dr. Kandi, Kenya's Social Health Authority reform has been central to a lot of the panels, the sessions and discussions at this conference this week. And we're really interested to hear how it links financing reform to benefit design. What has changed for a cancer patient from this reform? Over to you.
distinguished guests, colleagues, and partners, good morning.
Morning.
It is an honor to represent the Social Health Authority of Kenya at this important dialogue on financing sustainable cancer care. Africa is facing a growing cancer burden, but the deeper crisis is financial. Too many patients are still paying out of pocket, often at the cost of their livelihoods. Kenya has recognized this reality and chosen to act decisively. And we are beginning actually to see results. Today, as we speak, 43,661 patients are actively accessing oncology benefits under the Social Health Authority. Since July 2025, we have processed more than 283,171 oncology-related claims, with total payouts of approximately 6.8 billion Kenya shillings. That's approximately $52 million. These are not just numbers, these are patients. They represent access to treatment. They represent access to treatment, protection from financial hardship, and a system, however young, is actually working. At the center of our reforms is a shift to strategic purchasing, where resources are aligned with population health needs. Cancer care is no longer an afterthought. It is a core entitlement within our universal health coverage journey. We are focusing on 3 priorities. First, defining clear benefit packages that cover the full continuum of care, from diagnostics to treatment and also supportive services. What we are doing here, if I may go into just a little detail, is that when a diagnosis is made.
I'm just going to say that you have a QR code on the program. You can access the details of all the case studies. And because of time, I'm going to ask the speakers to focus on lessons learned and the way forward. Apologies for that.
Okay. Second, expanding access to medicines and technologies through structured partnerships. For example, patients with breast cancer can now access Herceptin at a standardized and more affordable cost, and this is in partnership with Roche. Third, strengthening financial protection through better provider payment systems, claims management, and digital verification. Because, again, without accountability, coverage does not translate into real protection. We are also strengthening primary health care to support early detection and timely referral, because late-stage cancer is far more costly to treat. But I'll be clear here. These reforms are not without challenges. Capacity gaps remain, infrastructure is uneven, and demand continues to rise. So the question is not whether we are perfect. The question is whether we are moving in the right direction and fast enough. And we believe we are, but we cannot do it alone. Partnerships between governments, development partners, and private sector is essential to move from policy to real impact. In closing, financing cancer care is not only a health issue, it's an economic issue, a social justice issue, and a human capital issue. If we can get this right, we do more than save lives. We protect households, strengthen economies, and secure future of our countries. Kenya's commitment is clear. No patient should be denied cancer care because they cannot afford it. Thank you.
Thank you very much. Thank you very much. That's a good kickoff on a case study that's working. Thank you. And our next intervention will come from Côte d'Ivoire. We have Dr. Maria Soun, technical advisor to the Ministry of Health from Côte d'Ivoire. She's going to reflect on their experience and their lessons and recommendations for the way forward. And she will be speaking in French. So if you need interpretation like I do, please use your Interprify app and headset, so we can just... over to you, Doctor.
Ok, merci Madame la modératrice. Je voudrais, moi aussi, à l'entame avec l'ensemble des participants à ce panel, exprimer l'honneur et la gratitude d'être présent à cette session au nom de Monsieur le ministre de la Santé, de l'Hygiène publique et de la couverture maladie universelle de Côte d'Ivoire, qui nous fait l'honneur de la confiance de le représenter ici à cette session. Je remercie également Amref et l'ensemble des partenaires et distingués délégués qui est ici présents pour braquer les projecteurs sur un sujet aussi vital, celui de la transformation de nos défis financiers en victoire clinique. Par rapport au sujet en ce qui concerne le refinancement de près de 400 millions d'euros de la dette en capital humain, il s'agit, je voudrais préciser ici que ce mécanisme financier n'est pas nouveau et la santé n'est pas un simple bénéficiaires de cette ingénierie financière, mais c'est surtout orienté, fléché vers l'éducation. Mais quand on sait que l'éducation, je dirais, l'investissement dans le capital humain est la pépinière, donc déjà pour aller vers des métiers innovants, disons des chercheurs, des enseignants, enfin l'ensemble des éléments qui puissent permettre de subvenir aux besoins de la santé. Donc, la transformation de cette dette en dividende pour le capital humain ou pour la dette humaine. Je voudrais juste rappeler que c'est un processus et c'est de la dette stérile en dividende fertile. Pour répondre à la question, le processus ivoirien ne repose pas sur une simple annulation de la dette, mais c'est une substitution stratégique. Donc, il s'agit du rachat de la dette. Et la Côte d'Ivoire avait une dette commerciale assez lourde et à court terme, avec des taux d'intérêt étouffants. Donc, l'État a utilisé un prêt de 400 millions d'euros pour racheter ses créances coûteuses avec l'appui de la Banque mondiale. Il s'agit d'une garantie multilatérale, comme je l'ai dit, grâce à une garantie de la Banque mondiale, nous avons transformé cette dette instable en un prêt à long terme avec des taux ultra avantageux. Cela permet également la création de l'espace budgétaire. Donc, cette opération a généré environ 330 millions d'euros d'économies sur 5 ans. C'est en ce montant que nous appelons le dividende. Et ensuite, nous avons des précédents au niveau de la santé. Au niveau de la santé, il y a 10 ans, comme l'avons dit, après justement la crise post-électorale que la Côte d'Ivoire a connue, tout le système de santé, tous les domaines d'activité étaient en branle. Et la Côte d'Ivoire, avec sa dette au niveau de la France, elle a payé cette dette, mais le retour, c'est que l'Agence française de développement, sinon la France, par le biais de l'Agence française de développement, a refinancé, c'est-à-dire remet cette dette à la Côte d'Ivoire pour pouvoir relever son système de santé. Donc, pour habiliter les centres de santé, pour sécuriser l'achat de médicaments. Donc, ces investissements ont eu un succès dans la santé et est l'un des piliers qui a donné à l'État et aux partenaires de la confiance nécessaire pour lancer de telles opérations à grande échelle aujourd'hui. Donc, l'État ayant des financements pour pouvoir soutenir le développement de certaines structures, de certaines infrastructures, donc va concentrer ses efforts justement au niveau local pour pouvoir financer d'autres éléments. Donc aujourd'hui, je pense que nous avons plusieurs enseignements, mais nous allons nous limiter à 3 enseignements en ce qui concerne la souveraineté sanitaire. Donc quel enseignement les autres nations africaines peuvent-elles tirer de notre parcours? Le premier enseignement, c'est pouvoir vraiment, comme on le dit, recadrer la santé comme un investissement, non pas comme une charge ou un coût. Nous n'avons cesse de parler de factures de santé pour parler de prévention du capital humain, soigner un cancer chez une femme en âge de travailler. C'est maintenir la productivité d'une nation. Donc chaque euro économisé ou dollar économisé sur la dette est réinvesti dans le dépistage précoce et évite une perte économique majeure. Donc il faudrait que nous sachions que l'inaction coûte plus cher que l'intervention. Le deuxième enseignement, nous avons la réforme sanitaire qui est la meilleure des garanties financières. Oui, exactement. Nous avons entamé une réforme sanitaire au niveau du pays, mais surtout avec de diverses stratégies. Comme on l'a dit, la couverture maladie universelle, d'autres l'ont déjà souligné, c'est un système de financement. Mais notre système encore est encore à l'étape, je dirais, embryonnaire chez nous en Côte d'Ivoire. Donc le refinancement en dividende santé ne fonctionne pas que si le système est capable d'absorber les fonds avec efficience. Elle a intégré les soins en oncologie complémentaires, comme je le disais, à la couverture maladie universelle, en renforçant notre système et en multipliant par 5 le nombre d'oncologues. Ensuite, nous avons prouvé aux partenaires financiers que le dividende santé produit des résultats réels. Une réduction de 25% dans le cas du cancer ou des maladies non transmissibles en général, de la mortalité de 25% du cancer du sein avec la mise en place d'infrastructures, notamment le Centre national de radiothérapie à Alassane Ouattara, et nous avons un autre centre en construction dans le pays pour véritablement prennent en charge ces pathologies cancéreuses, comme avec la plupart des maladies non transmissibles, qui sont, comme on le dit, des maladies à transition épidémiologique. Nous avons longtemps investi dans la prise en charge des maladies infectieuses sans pour autant faire des planifications, des projections sur ce type de pathologie. Mais aujourd'hui, vu que ce sont des pathologies assez onéreuses et coûteuses, on ne peut pas les impliquer ou les introduire directement ici et maintenant dans la couverture maladie universelle, de sorte à éviter un déséquilibre financier au niveau des différentes caisses. Mais progressivement, avec des stratégies comme la gratuité ciblée, où l'État prend en charge les soins, c'est-à-dire l'État se mobilise des financements sur son budget national pour prendre en charge ces soins qui sont assez onéreux pour ces patients que nous venons de tuer. Donc, effectivement, comme l'a dit, notre réforme a intégré les soins oncologiques en complément de la couverture maladie universelle. Donc, en renforçant notre système de santé, notamment multipliant le nombre d'oncologues, nous avons démontré aux partenaires, comme je l'ai dit, que le dividende santé génère des résultats tangibles. Et nous l'avons montré tout à l'heure, une réduction de 25% de la mortalité pour le cancer du sein au niveau du Centre national de prise en charge du cancer. La première fois que le ministre actuel est arrivé, il a demandé à chaque responsable de programme de savoir quelle est l'épidémiologie, quelle est l'incidence. Lorsque le directeur coordonnateur du programme de lutte contre les cancers a dit « Aujourd'hui, nous avons comme première cause de mortalité le cancer », mais toute la salle s'est réveillée, a été étonnée. Mais effectivement, puisqu'on a les deux cancers prévalents chez la femme, le cancer du sein, le cancer du col de l'utérus, qui lui, à lui seul, on a une mortalité de près de 50% des patientes atteintes. Vous voyez que le danger et l'urgence, là, se présentent. Le troisième enseignement sur lequel nous allons chuter, peut-être porter plus d'attention, c'est le partenariat public-privé comme levier de risque partagé. Et avec les laboratoires Roche, depuis 2014, l'État allait dans dans un partenariat de partage de risques à travers une convention. Ce n'est pas une relation, contractuelle, commerciale que nous avons avec Roche. Nous avons demandé, et ça aujourd'hui, nous disons merci à la vision, parce que pour avoir ces éléments de financement, il faut avoir une vision. Et cette vision, elle doit être soutenue par un charisme, celui du leadership, mais ce leadership-là, il faudrait que ce soit accompagné d'action, de prise de décision et d'action. Donc, avec Roche, comme je l'ai dit, depuis 10 ans, c'est une référence de cette stratégie-là. Et aujourd'hui, d'autres laboratoires frappent à la porte pour pouvoir rentrer dans ce partenariat avec la Côte d'Ivoire. Et dans ce partage de risques, Roche accompagne la prévention, qui est un élément très important au niveau santé publique, et le diagnostic et le plateau technique. Cela nous a permis, comme on l'a dit tout à l'heure, de quadrupler nos plateformes de mammographie et de décentraliser les soins hors d'Abidjan. Et aujourd'hui, nous avons un mammographe mobile pour aller vers les communautés. Tout à l'heure, notre sœur a présenté l'exemple d'une femme qui vit, pour aller vers les communautés, dans les communautés, pour la prise en charge, car les patients ou la pathologie du cancer n'est pas que seulement ceux qui vivent en ville, mais dans les coins aussi reculés que possible. Donc, sur ce thème, je voudrais vraiment, pour conclure, dire que la souveraineté sanitaire de l'Afrique ne viendra pas de l'aide extérieure, mais de notre capacité à transformer nos propres contraintes financières en actifs stratégiques. En Côte d'Ivoire, nous avons montré qu'en changeant le récit, en passant de la gestion de crise à l'optimisation de la santé populationnelle, nous alignons les intérêts de la santé avec ceux des finances. Chaque euro engagé dans l'innovation n'est pas un coût que nous subissons, mais un placement dans la compétitivité et de notre continent. Améliorer la prise en charge des maladies chroniques et des cancers, c'est sécuriser notre croissance future. J'invite donc l'ensemble des pays à ne plus voir la dette comme un fardeau, mais comme une opportunité à bâtir l'architecture de santé durable et souveraine. Je vous remercie.
Thank you very much. Thank you very much, and I am sorry to have to cut you off, but we do need to get through all our presentations, and we're really, really late at the moment. So I'll move straight on to our next case study. We have Mariam Musa, from Director of Operations for the National Health Insurance Authority in Ghana, and then she will be followed by the Nigeria case study by Dr. Adewale from MedServ, Sovereign Investment Authority, Advanced Medical Services in Nigeria. But we'll go straight to Dr. Musa. Please, can we be succinct?
Okay.
Focus on the lessons learned and recommendations, please.
Okay, so thank you very much for the opportunity. Before I mention the lessons learned, I'd like you to understand what our financing shifts are. So for cancer care, we're doing two very important things. We're shifting the way we finance cancer care in the country. As you know, for us in Ghana, we've had a resilient health insurance system that has been running for over 2 decades. So ours is not about adding new programs, but looking at how we shift around the funding. So we're doing two very important things. The first thing is that we are front-loading the health system with preventive care. And we are doing this through what we call the free primary health care program, where we are removing access and financial barriers to early detection screening service for the entire population. Now, this is not a parallel system. It is subsumed under the already existing National Health Insurance Scheme. And it's not only about access, but it's also about cost control at the system level. Then we have another financing stream, which is to protect households from catastrophic health expenditure, because we all know how expensive cancer care is. And we're doing this through a dedicated chronic disease financing model we are calling the Ghana Medical Trust Fund. Now, what this fund will do, and it's a domestic ring-fenced allocation, so there's some kind of stability there, would be funding primarily cancer cases. We already fund breast cancer under the National Health Insurance Scheme. So we are adding ovarian cancer, we are adding cervical cancer to it as well. What's the reason for setting up this fund is because we have realized over the past 2 decades that cancer cannot be properly, sustainably managed under general insurance pools. You need a dedicated financing to take care of those high-cost cancer treatment. Then between these two financing streams that is under our reform, we have the already existing National Insurance Scheme, which is the main pooling and purchasing financing mechanism for our health system. Now, in these two reforms, it is doing a very important thing. It is serving as the system integrator. So when we pick you up through the free primary health care early detection, you get your diagnostics funded through the National Health Insurance Scheme, and then you get the high-cost treatment funded under the trust fund. Now, this is very important for 3 main reasons. The first is that it is enforcing the treatment, the prevention first logic, which is we pick you up, we diagnose you, and then we get you treated. The second is that it is...
Again, I would stress they do have access to the detailed description, so can we focus on the impact?
Yes, so,
thank you.
Well, the impact is, I mean, it's there for everyone to see. The NHIS has historically funded curative care. So what we're doing in the preventive space, it's very phenomenal for us as a country. We envision that lots of people will be captured very early, and by so doing, we're making the investment case for reducing the cost upstream. The second thing is that now we are defining our own priorities. We say what we want to cover, and we align that to our financing so that we can adequately fund cancer care in the country. So that's it for now.
Thank you very much. Thank you. And I would urge the audience, please use a QR code on your program to look into the case studies in detail. And our final case study is Dr. Adewale. Please go ahead.
Thank you. Good morning, and thank you for having me here. So first, for the first thing, I'll say that I do not represent the government of Nigeria. So I stand at a different precipice, not that I represent patient advocate. My name is Tolu Adewale, as I said.
Why don't you take this one?
Oh, thank you. Thank you. But what I will say, healthcare, we need to begin to demystify when we look at healthcare. Healthcare, like every other thing, has 2 sides. There's a supply side and there's a demand side. And so when we're talking about financing, what are we talking about? Are we talking about the demand side or the supply side? I stand and represent a company where we are a service provider. So as again, what does that mean? It is on the supply side. Now, what we've been able to do, the question is which comes first, the supply or the demand? And can people be able to pay What we've been able to demonstrate in Nigeria through MedServ is that actually with supply, we can actually create demand. And that we've done. There are three components that we need to look at. The three things that make healthcare: infrastructure, technology, and human capital. And if you do not invest in any, or if you invest in just one or two of the three, it's going to be a catastrophe. And so what we've done is to invest in the entire three components, because what every patient wants is equitable access to quality care. And like a grandmother used to say, the profit is on the buying. And so because of that, you need patient capital, because it's patient capital that is able to translate to the reducing the cost of delivering care ultimately to the people of the country. And to do that, you need to then be able to leverage on technology. And to leverage on technology is to then to be able to increase access. And what we have done and demonstrated in Nigeria is that for cancer care, prior to 2019, there was only one epileptic linear accelerator in Nigeria. Now, we invested in a center with 3 linear accelerators. And between then, if that was not started, and then there's been a plethora of other cancer centers in the country, those 15,000 would either have died, or less than 10% of them will have been able to go outside and access care. Now, it took us, we can rule out data, it took us 3 years to be able to achieve 50% curative and palliative care. But this was only possible, and the kind of patient we attend to are bottom of the pyramid and middle class. What has now happened, and the success of that story, is that now we have DFIs, like IFC, just in February, invested $24 million into MedServ as part of our expansion plan. So it is possible to crowdfund, but you have, as a country, need to demonstrate that you can actually on your own put your money there and demonstrate that success is possible, and then you'll be able to attract a lot of foreign capital. It is never going to work the other way around. I have the institutions in the US where and the philanthropy is something we need to begin to look at. Patient capital from government, from sovereign entities, then philanthropy. In the US, a hospital like Memorial Sloan Kettering, in a year, gets over $600 million philanthropy. How many people here, instead of buying the next Rolls Royce or the next Ferrari, can you just put that money into healthcare and target outcomes and say that, look, if you can treat 10 patients, we put down the money. And that we have done at the center, where we have what we call the MedServ Indigent Support Program. So people who cannot even pay at the bottom of the barrel have a way to be able to access care, and we've been able to begin to get people to actually donate into that. But I will say something. We need to do this together. We need the OEMs, we need the pharma. If the cost of the drug is at procurement is already high, you cannot deliver care at a reduced price. So we all need to sit around the table, and I've told the OEM, Paul is there, we sat on different panels across the world, and I've always said it, there has to be differential pricing. For equity to happen, what you get the cost of the drugs to Herceptin or any other drug in Africa cannot be the same in OECD. And I think that's where we want to stop. That we need to look at this all over again, put in patient capital, attract more DFIs, and then the profit. Delivering more is in the cost of procurement. The cost of buying has to be low to be able to deliver more. Thank you.
Thank you very much. Thank you very much. And that was a perfect conclusion to we've heard different approaches, I would say complementary approaches to how we address this situation. Unfortunately, we are so short on time that I am going to take a chairperson's privilege and take one question. It needs to be a succinct question. I do not want an essay, and I do not want your commentary, a question for any of our keynotes, our panelists. So, which hand went up first? There was that hand there went up first. So please introduce yourself briefly, straightforward question. We have a moving mic somewhere. Can we get the mic to the gentleman, please? Thank you. He's over there.
I'll go to
I'll go to the lady. And please, I know there is a big keynote plenary happening in a few minutes. I'm counting on the fact that this was a system-wide delay and they might be running late also. So if you can just indulge us and give us a few more minutes here. Over to you.
Thank you
please
very
be succinct.
Yes. Nick, Senior Advisor to the Secretary General of the United Nations. So on access to finance. So thank you very much to the speakers. To be concrete, so we have established that PPP is really a cost-efficient when it comes to the treatment. But now, I have heard from Nigeria, from Ghana, from Kenya, and we know that one of the solutions that we have to take in consideration is the genomics behind it to go to the care treatment, to actually go straight to that. So now, before we start talking to a global health bond, as someone mentioned, I was talking to someone in the industry, we have to turn this into a business case. What are your countries doing? Thank you very much.
Thank you. I'll take the second question, then we'll come to the responses. It's the lady right opposite me there. I'll take one more, that gentleman.
Yeah, can you please give it to me?
Can use the... okay.
Well, thank you very much, everyone. I'm Dr. Radwa Saeed Abdulavim from Cairo University Hospital from Egypt. So that part of Africa, I'm very impressed with all the input. My question is, in Africa, we have a lot of indigenous modes. I just assisted in traditional medicine session, and the people are also part of the finance. They're actually part of the broadcast. Why aren't we using this? Thank you.
Thank you. Final question, and then we'll take all three. I've forgotten.
Thank you, Madam Chair. Mine is about, I've not heard about a cancer registry. I think it's very important that countries and regions come up with cancer registries on the types of cancer, on the mapping across countries, across regions. But Madam Chair, I am a member of parliament, but I'm also a medical doctor. We can't take away the importance of pieces of legislation.
I'll stress you to move straight to a question, sir, please.
Thank you, Madam. Should I proceed?
Question.
Yes, what's the role of legislation? As a member of parliament, there are acts that speak to cancers and how we can bring down the cancers, the public health acts, tobacco control acts, alcohol acts, narcotics and psychotropic agents, who gives out morphine and all things like that. So I would need that to come out more in the discussion. Thank you.
Thank you very much. And we'll take one question online.
Yes, sure. We have a couple of people, more than 100 participants, and the question, we have a couple of questions as well.
Take one.
I'll take one. From Kasim, he's based in Ethiopia. As we rethink health funding, how can we better integrate livelihood protection programs into health insurance models to prevent families from falling into poverty due to out-of-pocket expenditure? Thank you.
Thank you very much. So we have a series of questions, and I'm not going to ask everybody to answer each one. If any of the panelists want to pick a particular one, so I'll talk to Dr. Gladwell. Which one are you wanting to pick on?
I'm going to take the one about genetics.
Yes.
And I'll combine that with the one about research.
Good.
When I spoke about the cancer journey, I said that all our policies have to be driven by research and data. And therefore, the question about cancer registries and cancer mapping, very good concept. When we map cancer, even in Kenya, the distribution of cancer is very different. We find high incidences of esophageal cancer, very early onset in areas around Nandi and Western Kenya. And when we do cancer mapping and development of data, and also next generation sequencing, so that we can also come up with the targeted treatments, which I have mentioned that there are some racial differences. So some of our patients tend to be a little different from what we read in the textbook and what has been heavily investigated. When we map cancers, we'll come up with centers of excellence. We can't do everything all at once. We can create a center of excellence in esophageal cancer, in the part where that's the biggest problem. In hepatocellular carcinoma, in Eastern Province, where we have aflatoxin and the rest. And of course, have pockets where we are collecting, specimens and blood to be able to describe some of these NGS and genetic syndromes that we have. Thank you.
Thank you very much. And thank you very much. And we're going to go to you for the response to the question about traditional medicines.
Okay, fantastic. So the question is on messaging and how can we start harnessing the power of the community so that we also increase adherence to treatment and other approaches. And how I would want to frame it is that we know the knowledge on cancer, we know about prevention, but it's not translating into action on the community or even access to care. And when I mentioned about the health bond, what I meant was that we look across board to start thinking about how do we address some of these issues. What you talk about is stigma in the community, because people have a trust of their health, of their traditional healers more than they trust the healthcare system. And that's an investment case that we start looking at how do we invest and start innovating around its uptake. When we have these IEC materials as the African Cervical Health Alliance, they're already open source and readily available. All we need is some support to be able to customize them to the region, to the culture, to the people, so that we're able to pass the message. Cervical cancer is preventable, and we have the tools to do so. Thank you.
Thank you very much. Dr. Adewale, I'd like you to take the question on investment cases, if I may.
And I'm happy to talk about it. I mean, when people talk about PPPs, they need to really be clear what they want. Is it, and there are several models of PPPs. There's build, own, transfer. There's build, operate, transfer. There are several. So we need to be clear and specific. But basically, when you talk about PPP, you are talking about the private sector injecting capital and into a government establishment to then make it more efficiently run and to make it more profitable. Now, we need to be very careful what we're asking for. Turning anything into a business case, even within the government, they should be able to look at everything as a business case. So for the Sovereign Wealth Fund of Nigeria, there are two things. We have two KPIs. There's a financial KPI, and then there's a social KPI. And those two things need to go hand in hand when you're talking about healthcare. And the way to do it is to look at things what we call cross-subsidization. Now, the MedServ model, one of the reasons why IFC fell in love and was able to invest was because of that. So because it's about driving equity. So it depends. So first, I will ask, what is the objective of the PPP? Is it that the government has these assets and is completely incapable of running it efficiently? Or government does not have enough money to be able to distribute and have access across the country? Because there are two different investment cases. Because then you have to be able to look at which one of them might need a viability gap funding. If you're talking about on the outskirts, like where they said where they said the lady Sammy came from, in that kind of place, no private person will be able to invest his money and will make money and will be profitable. So you need to be able to look at things what we call the viability gap funding, and the DFIs. UN, all of them are World Bank especially, is very, very big on that. They are able to come to that. But the other thing you must be able to say, actually, if we put a linear accelerator here, how many people are here? Are there even the doctors to demand this thing, even if you go as low as primary health care. And so we need to, with your PPP, you need to think about things like task shifting. You need to then make a proper, do it in a business case. I mean, if you're talking about Aga Khan Hospital, I mean, it's very easy. Anybody will put their money there and they'll make profit. So then again, what it then does is that PPP then comes in where government knows that, look, where they can then, government, instead of investing in somewhere like Nairobi, can move their money and then let the private sector there, and then where there's more social needs and then can move there and then run that. So there's several models, but everyone needs to look at it in a holistic manner and ask yourself, what do I want to achieve in making this? But it has to be equitable. That's what I would say to you. So it's the different things, and we can continue the conversation after.
Thank you very much. And I think that's really important, how the PPP can complement what government has so that they can function and therefore ensuring access. And as you mentioned, making sure that equity and inclusion are central to the access to what you have. Thank you very much for that. We had one question on the role of legislation, and Dr. Meli would like to take that one, please.
Thank you. In my remarks, I reference a lot of acts that our government, through our parliament, developed to set a stage into implementation of universal health coverage, where cancer care is mainstreamed. But before that, we really appreciate the role of parliamentarians, and I want to make it very clear that without laws being created, there is no way resources will be allocated. These are very clear policies. For instance, in Kenya, more than a decade ago, the Cancer Prevention and Control Act was enacted by Parliament that created the National Cancer Institute of Kenya, which is now able to receive resources from our taxpayers' money through Parliament that is now deployed in implementation of cancer care. Now, tobacco laws in our country are very clear. And it's important to mention that currently, out of tobacco control programs in Kenya, we are now investing in cancer care because we do recognize that tobacco is the single most, vertical, horizontal risk factor for all cancers. And it is important that we also engage parliamentarians in providing oversight on how these resources are being utilized, as well as agents of creating awareness also, because parliamentarians meet the people all the time in the communities, in the villages. They are representatives. They are able to advance our, cancer prevention efforts. And more often when we interact with parliamentarians, I have always threatened them that if they don't make the right policies, they are also affected, because in our country, we've been in the recent past lost several parliamentarians to cancer, and therefore it is a reality that they are also affected, and they have a responsibility to support service delivery through different policies that they developed and also enact. And allow me to also mention that Kenya has a very robust national cancer registry, since the question came from the same member of parliament, and we are an IAC designated training center in Kenya for cancer registration in sub-Saharan Africa, and we have very strong population-based cancer registries as well as hospital-based cancer registries that guides our planning as well as policy development, and also sets infrastructure for research. Thank you.
Thank you very much. And we had one other question about livelihood, and this is, I suppose, is relevant to the out-of-pocket payment question. I'd like to ask you to take that one, please.
Thank you, Dr. Larry. For us in Ghana, I think it's something that we integrated right from the beginning of our social health insurance scheme. So we have what we call the livelihood empowerment against poverty, which is a social protection program. What we have done is that because beneficiaries of that scheme have other complementary services like free education, etc., we take the health component. So anybody who is under that scheme automatically gets free registration onto the National Health Insurance Scheme, and I'm happy to say that they form more than 50% of our membership on the National Health Insurance Scheme. So that's very good. We take them into consideration in everything that we do, free access, and when this cancer financing has taken them again into consideration, because the community-based and the household home visits that we're envisioning under the free primary health care, our primary targets are people like those under the livelihood empowerment programs.
Thank you very much. It's really unfortunate that we are so late and we can't take that many more questions, but I will take the chairperson's privilege and ask one myself. And that is that we've heard about financing systems, approaches that are disease vertical, they are specific. And with the expansion of NCDs generally, we know that vertical programs are challenging for sustainability. And you reminded us here of the key issue, which is the patient at the center. So the question I want to ask any of our speakers today is, how do we ensure that these financial solutions do not actually further fragment an already fragmented ecosystem? I know it's a challenging question. I would like to hear, I'd actually like to put it to you, Dr. Asma, because you mentioned that your approach was very much trying to look at the different pillars of the interventions. But if you could just give, I know it's a take-home question, but a couple of key points would be welcome. Thank you.
Ok, merci Madame la modératrice. Je pense qu'il faudrait que nous puissions, aujourd'hui nous sommes dans une transition dans tous les systèmes économiques. Les partenaires, que ce soit Gavi pour la prévention en termes de vaccins, que ce soit même avec la décision du président Trump, tout de suite, il faut qu'on puisse évaluer réellement les besoins et que les systèmes de santé, à savoir les ministres de la Santé, les ministres de l'économie et des finances, même le ministre du plan du développement, qui a le dividende démographique, on voit qu'aujourd'hui, les secteurs sur lesquels il faut investir, il y a la santé, l'éducation et la sécurité. Donc, si on ne met pas cet équilibre-là, on crée toujours ce déséquilibre et derrière, la santé est comme un réceptacle. Donc, toutes les actions viennent se déverser au niveau du système de santé. Donc, qu'est-ce que nous faisons? Aujourd'hui, monsieur le ministre de la Santé, vraiment, il prend son bâton de pèlerin et il fait son plaidoyer. C'est du pragmatisme. Qu'est-ce que j'ai besoin pour soigner ma population? Donc, il fait le plaidoyer auprès du président de la République. Tout de suite, quand la décision du président Trump de retirer les financements, il a pris son bâton de pèlerin, il allait voir le président de la République. Il nous faut des financements pour pouvoir continuer la prise en charge. Et c'est pour cela que je dis, la souveraineté financière, nous devons nous l'approprier. C'est vrai, nous avons les stratégies. Au niveau des PPP, il a parlé, la santé est un domaine social pour lequel aujourd'hui, on ne doit plus craindre de dire elle est budgétivore, mais il faut voir derrière je dirais, ce qu'on peut engranger. Parce que déjà, je vais prendre un peu au niveau commercial, les laboratoires font des promotions pour pouvoir augmenter leurs ventes. On doit faire aujourd'hui la promotion de la santé pour attirer les capitaux, la prévention et économiser sur les achats ou les médicaments par rapport à la santé curative. Je vous remercie.
Just one little thing. We've talked about research and data, making our decisions. But let's think about working as a bloc in Africa. We're talking about all these new targeted treatments. How can they become accessible to our patients? Are they out of reach? Shall we remain on our traditional aspects and fragment what we already have? Let's think about block negotiations of quantity discounts. Let's think about mass production of drugs. The big people with the money can make drugs. The little people, as we were discussing the other day, can make syringes and needles. They can provide vaccines. We need to have pooled procurement of some of these drugs. At the expense of being in trouble with the chairman, I'll tell you the story of a drug called Herceptin. Herceptin is very important for breast cancer. I wanted to tell you how a country decided to make Herceptin, call it Herculon, and provide at a third of the cost.
That is, we are going to interview and record that, add to the recording of the session, because that's actually a very interesting case study. But we are unfortunately out of time. And I have Gitinji's permission to usurp his place and bring us to a close. So first of all, can we have a round of applause for all our contributors this morning? Thank you very much. I am not going to attempt to summarize everything that was said. We don't have the time and there's so much importance. I'll remind you that this was live streamed and recorded, and the recording will be available after that, so you can go back to that. As said before, the details of the case studies are the QR code. You can download those and study them in more detail. One thing we've heard here is that cancer financing has to be judged by how much it changes the life experience and the journey of the patient. We need to make every contact count. We need to ensure the funding follows the patient, and we need to ensure that we take a whole patient, a whole life course approach to our financial investment. We've heard of different approaches to try addressing this financing solution, from social health insurance to public-private partnerships, to use of sovereign wealth investments. We've seen the challenges and the opportunities that can emerge from these. I've always believed very much that there are solutions to our African challenges already in play across the continent, and we have shared some of the case studies that demonstrate that, and I will urge you to reach out to these countries if you're in the beginning of designing solutions for your own country, your own constituency, to actually reflect on whether these case studies are transferable to your own context. I think a recurring message here is that there needs to be an alliance between the patient, the physician or clinician, the healthcare system, the politicians, the financiers, and the public and private sector, if we're to come up with sustainable solutions that will address this complex and, dare I say, increasing problem. We haven't really touched on some of the challenges around the genomics and the research agenda that has not been tapped in terms of cancer. We're seeing the phenotypes of cancer showing to us that we know that the data coming out of Northern Europe and North America does not address the issues on our continent. And so a place that I would like to end on is to urge our governments to invest in research for cancer, so we can better understand the burden, we can better understand the interventions, and how to achieve the best outcomes for our patients. So I'd like to close by thanking Roche and Amref and WHS for the session and for inviting me to have the privilege of moderating this morning. Thank you very much, and I apologize again. Please, you are 20 minutes late for the next session. Thank you.